Okay. Assalamu alaikum, everyone. My name is Rawad, Turko. I'm a fourth year medical student. And today, inshallah, we'll be going through the first crash course of the lower gastrointestinal disorders, which is going to cover a couple of lectures like abdominal pain, diarrhea, and constipation, intestinal obstruction, inflammatory bowel disease, and finally, diverticular disease. Um, Probably by the time this recording comes out, you guys would not have taken diverticular diseases yet, but it's really, really easy, so you don't have to worry about it too much. Just maybe you can skip that part of the pile and then come back after you've taken that lecture, or not. It's up to you. Okay, but before we start, I want to go through the anatomy and embryology really quick so that we could tie in the clinical scenarios better to our baseline knowledge of anatomy and embryology. Okay, so here we have this embryo, and as you guys know, the gastrointestinal tract is formed by the primitive foregut, midgut, and hindgut, which is going to form different parts of your GI tract, which we'll talk about later. Now, in the fifth week of fertilization, the midgut is actually going to herniate out into the umbilical cord, as you guys can see here. Okay, and then it's going to basically split into the cranial and the caudal limb of this midgut, which is what we call the primary intestinal loop. Okay. Once that happens, basically these two cranial and caudal limbs are going to rotate around the axis of the superior mesenteric artery, which is also part of this structure that's herniating out into the umbilical cord, as you guys can see here from this red structure. It's going to rotate around 90 degrees. Okay. And then in the 10th week, it's going to retract back into the abdominal cavity. As you can see here, this was here before. It was in the umbilical cord, and it's going to retract back into the abdominal cavity and then continue the rotation another 180 degrees for a total of 270-degree rotation. Now, it's a little bit, too much math. You don't need to know this in great detail, but the whole point of this is that eventually this rotation is going to have your cecum be right here to the right or lateral to your small bowel, your intestines. Okay, that's the whole point of this entire rotation. The cecum and in general, just the colon and the transverse colon, the sigmoid and the descending. Okay, now. Let's say we have a problem with this rotation. So instead of rotating this total of 270 degrees, it's not going to rotate the full 270 degrees. It's going to rotate maybe only 90 or 180 degrees. What's going to happen is that the cecum, which is supposed to be here, is actually going to be, sort of like flipped upside down. It's going to rather be up here. Now, this is going to form something, or this is going to form adhesions to the retroperitoneal sort of wall, and it's going to form these fibrous bands. Now, these fibrous bands are called LAD bands, LADD, LAD bands. And do you see which structure they're overlying? They're overlying the duodenum. So let's just say we have a clinical scenario where the midgut doesn't rotate the full way like it's supposed to. You have intestinal malrotation, and you get formation of these fibrous band that are going to constrict and obstruct the duodenum. What do you think that's going to present like? It's going to present similarly to this. So you can see here the cecum is sort of superior, and it's in the right upper quadrant as opposed to the right lower quadrant. And it's going to compress on the duodenum through these LAD bands. Okay. And basically it's going to present as abdominal distension and bilious vomiting in newborns. Now, do you guys know why this would be bilious vomiting? Well, that's because the bile ducts and the common cystic ducts and all these ducts are going to drain out into the ampulla vater in the duodenum, or specifically in the second part of the duodenum, the descending duodenum. Okay, so if you get obstruction of this part, it might be distal to that ampulla, or distal to the drainage of these cystic ducts or these common bile ducts, and it's going to cause bilious vomiting when the infant vomits. Okay, so again, just know that the intestinal malrotation is something that could happen. It's a congenital anomaly of midgut rotation during the fetal development. You have formation of these fibrous lad bands that can lead to volvulus and or duodenal obstruction. All right, volvulus is something that maybe you'll learn in more detail in your upcoming PAL session, inshallah. All right, so again, just to summarize, we have the foregut, the midgut, and the hindgut. All right, the foregut is going to form these structures, so your liver, gallbladder, stomach, pancreas, up until maybe the second part of the duodenum. All right, the midgut is going to form the remaining part of the duodenum and the small intestine up until the transverse colon, and then hindgut is from transverse colon to the rectum. All right. And the foregut, as we already mentioned, it's supplied by the celiac trunk. The midgut is supplied by the superior mesenteric artery, and the hindgut is supplied by the inferior mesenteric artery. All right. So this is what it's going to look like, obviously in an adult. Now, the reason I'm showing this picture is that a lot of your symptoms in GI a lot of your symptoms are going to point to where exactly the problem is in the GI tract, just purely based off of what sort of symptoms you have. So let's say, for example, we have some sort of obstruction or some sort of problem in the small intestines. Well, we know that the small intestines from GIT first year, we know that they're responsible mainly, and here I'm basically simplifying it a lot, but this is just so that we can make more sense for the actual clinical scenarios. Mainly responsible for nutrient absorption, so stuff like vitamins, stuff like vitamin B9, your bile acids, your fats, all these things. So if you have any sort of problem in your small bowel or in your ileum and your jejunum, basically it's just going to manifest like with things like fatty diarrhea, with things like malabsorption and malnutrition. All right. And your colon, on the other hand, is going to be responsible for things like water reabsorption and eventually formation of the stool. So what that's going to present like is like diarrhea, for example, or constipation if you have problems in the colon. Now again, I'm simplifying it a lot, but this is just so that you can get the overall idea. Okay, another thing I want to point out is that the colon has sort of its own intrinsic ability to contract and propel the stool towards the rectum. Okay, and this propulsion is controlled by these pacemaker cells called the interstitial cells of Cajal. All right, now if you have a problem with the pacemaker of or your intrinsic motility of the colon, it's either going to be too quick, so either it's going to be hypermotile, or it's going to be hypermotility or hypomotility. Okay, so let's just say, for example, that the stool is spending too little time in the colon. That's not going to allow enough time for water reabsorption, and it's going to cause diarrhea. Okay, so that's why we say hypermotility of the colon causes diarrhea, whereas hypomotility, where the stool spends too much time in the colon, you're going to have too much water reabsorption, and that's going to cause constipation. Okay. So again, just to take a closer look, now just imagine we took away all of uh, all the bowels and all the stomach and everything. We have the superior mesenteric, or sorry, this is the celiac trunk right here, and then we have the superior mesenteric trunk or artery right here, and then the inferior mesenteric artery right here. Okay, and if you could imagine, what structure do you think would be immediately inferior and sort of passing right under the origin of the superior mesenteric artery? Well, that would be the duodenum. Okay. So, and this angle that's caused the angle that's basically keeping the superior mesenteric artery away from the duodenum is basically held in place by mesenteric fat. Now, let's say we have a condition where a patient is maybe bedridden, or they're on an extremely strict diet where they're losing a lot of weight very quickly, and then they end up with bilious vomiting and signs of obstruction. That's called your superior mesenteric artery syndrome. Okay, again, it's characterized by intermittent intestinal obstruction symptoms when the superior mesenteric artery and the aorta compress the third portion of the duodenum. Okay, so again, you have the SMA, your superior mesenteric artery, and then right underneath, right inferior to it, you get the duodenum passing. Okay, and this angle is formed by the fat, the mesenteric fat. So let's say you get loss of this fat very, very quickly, like in rapid weight loss, low body weight, malnutrition, whatever, or surgeries because you can be bedridden and not get enough nutrition. You're going to get loss of this fat, and it's going to compress the duodenum. Okay, and you're gonna end up with these symptoms of small bowel obstruction. Okay. All right. Now let's move on to abdominal pain. Okay. The main point of this slide is just to basically tell you that we do have these sensory neurons that are supplying the viscera of your GI, of your gastrointestinal tract. So you have the phrenic nerve supplying these structures, then your celiac plexus, mesenteric plexus, lowest splanchnic nerve, hypogastric. The point is that these nerves, this sensory supply is bilateral. That's why when you get pain that's visceral, like visceral pain, something is happening inside of the gastrointestinal lumen, then you're going to get very, vague location, very vague pain that's not going to be very well localized. You're not going to be able to point out and say, this is exactly where I'm feeling my pain because it's bilaterally, it's supplied bilaterally. All right, so it's going to basically focus to the midline of the abdomen. Whereas if this pain were to maybe go outside the lumen, of the GI cavity. It's going to irritate these peritoneal fibers, and you're going to be able to more accurately localize the pain to one specific spot. Okay? This entire concept is very, very extremely important to know in your physical examination or when you're getting a case of acute abdomen or somebody with acute pain and you need to localize the pain and you need to know what's sort of happening in the background. Okay? So again, visceral pain is poorly localized and it's midline due to the bilateral innervation of these of the viscera, and it's often secondary to obstruction, and the patient would be restless rather than, in, severe actual pain. But somatic pain is basically just what we call peritoneal pain, or when there's involvement of the peritoneum. Now, that could be because of the irritation of the GI tract itself with the peritoneum. Maybe there's inflammation going on and it's going to irritate the peritoneum. Or if there's perforation, or if there's obstruction, that's leading to maybe gangrene or something that's going to irritate the peritoneum. And you're going to get signs of peritoneal involvement. Now, these signs, guarding and rebound tenderness, are basically signs that are only going to be present when you have somatic pain. Somatic pain, when you see these signs, this is a surgical emergency. So a lot of the times you'll get a question of a patient with appendicitis or something like that, and they'll tell you there is some guarding. The the answer would be you do immediate surgery. Okay, and that's because this is a surgical emergency. As soon as the peritoneum involved, we know that this could lead to something that's a lot more severe. It could lead to perforation. It could lead to bacterial peritonitis, which is life-threatening, so on and so forth. Okay, and again, the somatic pain would be localized and it would be worse with movement. All right. Guarding is basically just when if somebody were to palpate your abdomen, you would unconsciously and without meaning to, you would flex your abdominal muscles to sort of protect your internal viscera from being palpated. Okay, this is a involuntary sign. And rebound tenderness is pain that basically, the pain still persists when somebody were to, take their hand off of your abdomen, you would still feel that pain. That's what rebound tenderness is. Okay. So another important thing that we're going to look for when we're doing our history and our physical examination are signs of referred pain. Okay, so this is just a nice diagram that tells you where the pain might be referred to, in the context of any specific pathology. So if you have sort of stomach pains, then it's going to be referred to right here. So we would call this the epigastric region. All right, sometimes it could radiate to the back. Diaphragmatic pain would radiate here to the right shoulder, but again, that's not important. Gallbladder here, small intestines right to the umbilical region. All right, and again, we subcategorize, or we sort of split off the abdomen into these nine quadrants, but most commonly it's just going to be your right upper, your left upper, your right lower, and your left lower quadrant. All right, but this is just a diagram to help you just sort of localize where the pathology is. Okay, so for example, right lower quadrant pain or pain in the right iliac is most commonly going to be from, either appendicitis or some sort of inflammation or infection going on with the cecum. Sometimes it could be the terminal ileum because the terminal ileum is very, very close. That could also present as right lower quadrant pain. Okay. All right. So again, when you're taking your history from a patient with abdominal pain, there's a lot of very helpful questions that you're going to ask. First of all, you're going to ask about the onset. So if it's acute onset, it may be pointing to something more serious like a perforation or an acute hemorrhage. Whereas if it's a gradual onset, it could be things like obstruction or just chronic inflammation. Character. So these are buzzwords that you're going to hear on in your question stem. So colicky pain is almost always referring to obstruction, colicky pain. Burning pain could be something that's like it's making you think of something that's like peptic ulcer disease or gastroesophageal reflux disease, things like that. If the pain is radiating anywhere, so pain radiating to the back, cramping pain, tearing pain. Tearing pain, by the way, is another buzzword for aortic dissection, but it could present as abdominal pain, obviously, if it's your AAA. Associated symptoms could be things like vomiting and nausea. This could be pointing towards things like maybe gastroenteritis, constipation or diarrhea. Obviously, weight changes or fatigue, which are things that are going to be more associated with chronic diseases such as inflammatory bowel diseases or maybe cancer. Okay. Timing is also important, especially if it's postprandial, which means after you eat. That could be pointing towards things like cholestatic pain, like gallstones, for example, or pancreatitis or things like that. All right. And if it's unrelated to food intake, then might just be a chronic inflammatory thing that's going on in the background. Nocturnal pain, cyclical pain, maybe in a female could be pointing towards maybe menstrual cycle abnormalities. Exacerbating and relieving factors. So if it worsens with movement, if it's relieved by fasting, if it's relieved by defecation, this is especially important in IBS. So irritable bowel syndrome is classically, the pain would be classically relieved by defecation. And if it's better or worse with food. All right. Now, you could also do inspection, and with inspection, you could look for things like surgical scars. Could be pointing towards maybe a surgical site hernia that has maybe it's maybe incarcerated or it's causing obstruction or things like that. Also, you could be looking for any hemorrhage, like a Cullen's sign that you could see with pancreatitis or any skin changes. And finally, on auscultation, you're going to be listening to the bowel sounds. Now, if they're hyperactive, if you hear that somebody has hyperactive bowel sounds, then it could be a sign of bowel obstruction because typically this like proximally to the obstruction, you would get more severe the segmentation or the motility thing that I talked about before, so that it could push the stool out of the GI. Now, if there's absent or markedly decreased sounds, it could be paralytic ileus or peritonitis, things like that. Peritonitis, especially when you have the peritoneum involved, it's going to basically freeze the entire, that's the way that I like to think about it. It's going to freeze the entire GI tract. So you could have absent sounds because the entire system is basically just on shutdown. Right? Now, moving on to diarrhea and constipation. So there's a specific way we define diarrhea. So it's an increase in stool frequency of more than 3 times a day of both consistency or frequency. Okay. And the cutoff line to decide whether it's acute or it's chronic is if it's less than 2 weeks, then we say it's acute. If it's more than 4 weeks, then we say it's chronic. Between the 2 to 4 weeks, it's still, a little unsure. It depends on the underlying cause, of course. Now, the etiology, we could categorize diarrhea in a lot of different ways. So we could say it's either infectious or non-infectious. It's either bloody or it's non-bloody. It could be motility related. Could be osmotic diarrhea, secretory diarrhea, or drug-induced diarrhea. Okay, so this is uh so the non-inflammatory and the inflammatory. The inflammatory we could also call exudative diarrhea. That's because you get actual mucosal damage, and because of that, in the stools you could see mucosal debris. You could also see WBCs, different cell types, and these are the pathogens causing inflammatory diarrhea. So you have Salmonella, Shigella, Campylobacter, E. coli, Shiga toxin producing E. coli, uh, again, enteroinvasive E. coli. So anything that's going to invade into the mucosa is going to cause exudative or inflammatory diarrhea. And then for parasites, you have classically your Entamoeba histolytica, which you guys should be, familiar with. C. diff also could cause inflammatory or exudative diarrhea. All right. And this is, again, because you have mucosal invasion or at least mucosal damage, it's very severe, typically also bloody diarrhea. Okay. Whereas in your non-inflammatory diarrhea, these are things that are just going to be, causing more secretions to be let out into the gastric or the GI lumen. So things like rotavirus, norovirus, adenovirus, or CMV, cytomegalovirus. Classically, your cholera is also going to be causing a secretory diarrhea. Um, and your parasites, you have Giardia, you have Cryptosporidium, and your Cyclospora. Okay. Again, you don't need to memorize these um, separately, individually. I'm sure you're gonna have your own micro crash course for GIT, inshallah, where you'll go into detail for a few of these, if you select one of these. But the whole point is that you just know how we categorize diarrhea. Okay. I'm not sure why this picture isn't loading. Anyways, it's just, oh, okay, there we go. And again, different sorts of food sources that can be a cause of infectious diarrhea. So raw seafood, classically with Hep A, also norovirus. Raw eggs with salmonella. We all know the salmon. You get salmonella from eating raw eggs, so that's where it comes from. Undercooked meat or poultry, very important to know. EHEC, extremely important because that's it might cause more severe disease course than some of these other infectious agents. Unpasteurized milk, so Campylobacter, Salmonella, EHEC again. Raw hot dogs or raw meat in general is going to be caused by Listeria, and then like canned goods by botulinum, of course. Okay. So again, when you're taking your history, it's sort of the same thing. Before we begin taking history, we want to sort of think about all the different causes of diarrhea that we can think of. So we just mentioned infectious, for example. We also know that there could be drug-induced diarrhea. So we're going to go through Socrates, first of all. Then we're going to ask about any recent travel, medication use, the diet that they typically eat that it could be very strongly related to the diarrhea. For physical examination, we're going to be mainly looking for signs of dehydration. That's going to tell us the extent to which this person is losing fluid in the stool. So tachycardia, reduced skin turgor, and capillary refill. For labs, we're going to check the electrolytes because you could see a lot of electrolyte abnormalities with diarrhea. You're losing a lot of ions in your stool. Stool and blood culture, obviously you do the septic workup if you're suspecting a infectious reason or infectious cause. But again, you wouldn't do a culture if it's a parasitic cause. You would do ELISA for parasites mostly. Fecal calprotectin is just it's a non-specific sign of GI inflammation that could be going on. So you also see this in IBD, for example, inflammatory bowel disease, which we'll talk about soon. And finally, you could do colonoscopy and to see if there's, for example, you diagnose C. diff through colonoscopy. You could check if there's any tumors or if there's any intraluminal adhesions or anything that could be contributing to this diarrhea. Okay, so again, the pathophysiology, just to sort of break it down further, we have watery diarrhea, which we can subcategorize into osmotic and secretory, inflammatory, which we briefly touched upon, fatty diarrhea, motility related, and infectious. So for watery diarrhea, we can split it into osmotic and secretory. Now, osmotic diarrhea is basically referring to anything that draws fluid inside of the GI lumen. Once you get something that's very poorly absorbed or poorly absorbed, it's going to draw in fluid, and uh, um, it's going to cause distension of the lumen, which is going to increase peristalsis. Okay, and this is anything that could be poorly absorbed. So in patients who have lactose intolerance, for example, they can't absorb lactose or they lack the lactase enzyme. So then all of that extra lactose is going to draw in fluid and cause an osmotic diarrhea. Also, exocrine pancreatic enzyme deficiencies. Okay, because that's what's going to help with your fat digestion, everything like that. Laxative abuse and celiac disease. And again, celiac disease is because you're not able or you have autoimmune destruction of the villi of your small intestines that are going to be um, basically absorbing all of those nutrients. And when you get that, you can have a osmotic fatty diarrhea with celiac. Okay. And secretory is basically anything that's going to cause, just like I mentioned before, secretion of ions into the lumen that's going to draw in a lot of water with it. Okay. So it's not necessarily something that you're intake, it's something that you're taking into the GI tract. It's more so a lot of the times going to be things like hormonal. So via hormone secreting tumors like VIPoma or villus adenoma could cause a secretory diarrhea. Classically, cholera is going to be the first thing that you think of when you think of secretory diarrhea. Okay. Now, how do we know whether something is secretory or if it's an osmotic diarrhea? Basically, we're going to look at the stool osmotic gap. And what we do here is we calculate the plasma osmolality, and then we subtract from that 2 times the stool sodium and the stool potassium. Okay. And if they're very high, if the stool potassium and stool sodium is very, very high, which we could expect in secretory diarrhea, then we would see that there's a very narrow stool osmotic gap. That's telling us that this is a secretory diarrhea. So the cutoff is 50. So if it's less than 50 milliosmoles per kilogram, difference between the plasma and the stool, then it's secretory. And if there's a very large gap, then that's an osmotic diarrhea. All right. Not sure why this picture isn't loading, but it's more of the same concept we were talking about. So we could skip it for now. This is mainly what we're focused on. So the difference between osmotic and secretory. So osmotic, again, like we mentioned, there's actually something that you're taking into the GI lumen that's going to draw in water and causes diarrhea. So if we fast, let's say for a couple of hours, this diarrhea is going to improve. You're going to have less diarrhea because there's nothing in the actual lumen anymore that's drawing this water in. Whereas in your secretory diarrhea, it's not going to actually get any better with fasting. Okay. So volume of stool is going to be very high in secretory diarrhea and very, very high stool ions like sodium and chloride. pH is going to also be very high because of these ions. And the osmotic gap is going to be very low in the secretory diarrhea. Okay. And the reducing substances, you just need to know that there's actual substances in the osmotic diarrhea that obviously you can run a bunch of tests on. So different examples. So again, carbohydrate malabsorption, such as in lactase deficiency, or galactose malabsorption, laxatives, and uh, different types of laxatives like polyethylene glycol or sorbitol. Sorbitol could also cause osmotic diarrhea. And secretory diarrhea, there's a defect. There could be a defect in the enterocyte. So this is a name of one of these syndromes. It's not very important. Mainly, it's just these that we're worried about. Carcinoid syndrome or VIPoma. Infectious causes like cholera or E. coli could also cause the secretory diarrhea. Okay. Moving on, we have the inflammatory or exudative diarrhea, which is, we mentioned before, it's an outpouring of inflammatory debris secondary to mucosal damage. This could either be infectious or because of an actual infectious agent, or it could be auto-inflammatory, such as an IBD, for example. Ischemia could also cause mucosal damage, radiation, and this disease, which is called microscopic colitis, which I don't think you guys took, so we're not gonna worry about it too much. You also have motility disorders, things like IBS, irritable bowel syndrome, diabetes, or hypothyroidism could also contribute to these things. Okay. Okay, what is the most common cause? I'm not sure what's going on with these pictures, by the way. What's the most common cause of hospital-acquired diarrhea? The answer is C. This is C. diff. All right, Clostridium difficile. Typically, you would see this in a patient who's on broad-spectrum antibiotics. Classically, the one that's associated with C. diff is clindamycin. Okay, just for your information. Now, we're going to move on to constipation. So constipation, as we already know, because I mentioned it before, is basically when you have the stool spending too much time. This is the way that I like to think about it. Spending too much time in in the colon, and that's going to cause too much water reabsorption. Okay. Or another way you could think about it is hypomotility of the interstitial cells of Cajal that I mentioned before. Okay. Or things that are keeping any sort of obstruction or anything that's keeping the stool inside, like a stool passage obstruction. Okay, so this is a picture here so that you could take a better look at the sort of stool passage, from the rectum to the anus. So let's say we have like an anal fissure or any sort of anal abscess or a rectocele, for example, or a cystocele, changes to the anorectal angle, this one right here, is also going to predispose to constipation because there is an actual stool passage obstruction. Um, and let's say, or for example, a tumor. If there's a tumor inside of the colon that's obstructing the passage, that could also cause constipation. Okay. So there is a criteria that we have to know for chronic constipation. It's the Rome 4 diagnostic criteria. It's right here. We're going to go over it in a minute. I'm not sure why all of these. Hold on. Let me just fix this thing really quick. Okay. So again, the Rome 4 criteria, which we'll go over in a minute, you have to fulfill at least three of these criteria for 3 months with symptom onset equal to or greater than 6 months before diagnosis. All right. And the different etiologies we have for constipation are constipation with no gross abnormality. So you could be suspecting something maybe metabolic or something maybe motility related. Or if there's an actual structural abnormality, it's going to be a lot easier to diagnose. Neurological etiologies, metabolic, psychological, or medication. Psychological is sometimes important because it's difficult to diagnose. But patients with depression, for example, like major depressive disorder, can present with chronic constipation. Okay. Again, this is the Rome for criteria for chronic constipation. So either two or more of these criteria must be present. Straining with greater than 25% of defecations, lumpy or hard stools, and you'll use the Bristol stool chart to determine what exactly classifies as lumpy or hard stools. A sensation of incomplete evacuation, anorectal obstruction, manual maneuvers required, fewer than 3 spontaneous defecations per week. Okay, and if there's insufficient criteria for irritable bowel syndrome. Okay. Now, the reason that there's so many of these criteria is that patients don't typically, they don't typically share what your view of constipation is. Okay, so they could not meet any of these criteria and still claim or still say that they have constipation. So that's why when a patient presents with constipation or they complain of constipation, the first question you have to ask is, what do you mean by constipation? Okay, because it could be very different from what you're expecting, and it could be something that's actually very normal, and they're just, maybe being a little bit dramatic and calling it a constipation. Okay. You're also going to ask about duration of this constipation, the onset, if there was anything that maybe was predisposing this constipation. Also, you're going to ask about, again, any medication use, things like that, past history. You're going to also ask about symptoms that maybe are going to raise a few red flags, like if there's any blood in the stool, when they're being able to pass stool, if there's any chronic change in bowel habits or stool caliber, like the actual stools themselves, if they look different than how they used to, that's also a red flag. It could be seen in cancer. In physical examination, again, we're going to refer to our set or our list of differentials that we have. So the etiologies like that I mentioned could be metabolic. So things like hypercalcemia, or things like hypothyroidism. So you're going to be looking for signs of hypothyroidism, for example, for thin hair and dry skin. For example, you're going to be, if it's a psychological reason, you're going to be looking for things like disheveled, if the patient looks disheveled, that's maybe because they're going through a depressive period. Unkept hair, for example, is something that you could see a lot in the depressed patients. Okay. Now, tests that we could run, uh, your go-to labs are always going to be CBC, ESR to see if there's any underlying inflammation going on, TSH, glucose, and calcium, obviously, because calcium could also cause, or hypercalcemia can also cause constipation. Now, there's special tests that you could do, like these ones, colonic transit study. I mainly want you to know the colonic transit study. I do remember getting a couple questions on it. So this is basically what it is. The whole study is that you give 24 rings, so that's the number. You give 24 rings, and then over the next 5 days, if there's more than 20% of these rings still present in the colon, then that's pointing to a very slow transit time of the colon, of the intrinsic motility, motile activity of the colon. So if you zoom in here, you could see the rings are all in the transverse colon here, and then they're going down into the descending and the sigmoid colon. Okay. So this would be day 5, and I think there probably are more than 20% of these rings remaining. So this is a slow transit time. Okay. All right. Who can tell me what the diagnosis is here? Well, I guess maybe pause the video and try to guess what the diagnosis is. So it's small bowel obstruction. The things that we could see that immediately point out small bowel obstruction are the air fluid lines here, the air fluid lines, classic for small bowel obstruction. Also something called the stepladder sign. So you get these dilated bowels that sort of look like they're on top of one another, like a stepladder. Okay, and we also have the valvular conaventes, which is basically these little lines that are going through the entire diameter of the small bowel. Okay, if you see these lines and they're stopping right here, then that could be a colon obstruction or a large bowel obstruction. But if they're going through the entire diameter of the lumen, then this is a small bowel obstruction. Okay, so these are the main things that you want to look for. So dilated bowel loops, air fluid levels, the stepladder sign, and the valvular coniventus to see if it's a small bowel obstruction. Okay, so again, small bowel obstruction. So it's basically when the normal flow of intraluminal contents is interrupted, fluid accumulation, and intestinal dilation. Basically, you get obstruction, and all of this intraluminal stuff accumulates and it draws water in, and you're going to get bowel edema, and then eventually it could cause ischemia or even gangrene in severe sign or in severe cases of obstruction. All right, so it presents with abrupt onset of abdominal pain, nausea, vomiting, and abdominal distension. Now, depending on the degree of obstruction, it could be very, very severe, or it could be mild. Like they could tell you, that it's just mild colic pain, and they're still able to pass stool, for example. Compromised blood flow due to excessive dilation or strangulation may lead to ischemia, necrosis, or perforation. Most commonly, it's caused by intraperitoneal adhesions. Okay, especially in a patient with a prior history of abdominal surgery, the most common cause is intraperitoneal adhesion. Basically, you got these bands, just like the LAD bands that we talked about before in intestinal malrotation. You're going to get these intraperitoneal bands that are going to adhere to the intestine from the outside and pull on it, and it could cause an obstruction. All right, and I'll show you a picture in a minute. An upright abdominal X-ray shows air fluid levels, and then we'll get into the management in a little bit. Okay, so this is what an adhesion would look like. So this is the intraperitoneal adhesions. Most commonly, that's what causes it. Now, in virgin abdomens, which means in patients who have never had, who don't have a history of a previous abdominal surgery, the most common cause are hernias, and this is an example of a hernia here, which can cause an obstruction. Okay, now again, you'll have another lecture, inshallah, on hernias, but just know that that's the second most common cause overall and the most common cause in virgin abdomens. All right. Other causes are Bezors, pseudo obstruction like paralytic ileus, electrolytes, and tumors. So Bezors are basically any sort of non-absorbable thing that can accumulate. Most commonly, or especially in question stems, it's going to be hair. So a patient with like trichotillomania, for example, somebody who pulls out, it's a psychiatric patient who pulls out their hair, maybe eats it. That's called trichotillophagia. Those hair cells or those hair tuft strands cannot be absorbed, so they're going to accumulate and eventually it's going to cause an obstruction. All right, so this is a picture of a Bezor. This is what it's going to look like. All right, and you can see it's made up, a lot of it's made up of hair. It could be like any sort of non-absorbable protein, like a milk protein, for example, that's not well absorbed, can sort of accumulate and also form this giant structure. Okay. All right, so the pathophysiology. So you get obstruction, and then the luminal fluid and gas accumulates, so you get distension. The intraluminal pressure increases, which causes venous congestion because now the blood flow can't escape. You can't drain the blood from the bowels itself. So you get bowel wall edema, and because of that, you get decreased perfusion because of the increased pressure, and that causes ischemia and then eventually gangrene and perforation. That's why obstruction, the immediate thing you want to do is put them on bowel rest. You don't want to really give them any more food, especially not per oral, so that you could prevent any further distension or further accumulation of contents that's going to exacerbate the distension. Clinical features colicky abdominal pain with bilious or feculent vomiting. Now, depending on where exactly the obstruction is, if it's higher up, if it's a very high small bowel obstruction, it's going to present immediately with bilious vomiting. If it's lower, and again, lower still small bowel, then it could be feculent, where it's like fecal-like matter that's present in the vomitus, which you can see if it's a lower small bowel obstruction. All right. So again, abdominal distension, obstipation, which is similar to constipation, but it's characterized by a complete inability to pass any stool or gas. High-pitched bowel sounds if it's early, and if it's late and or if it progresses to involve the peritoneum. You could have absent bowel sounds. Electrolyte imbalances, so you can have features of electrolyte imbalances like problems with heart rate, for example, or fatigue or muscle pain. Fever, peritonitis if there's strangulation and involvement of the peritoneum. Okay. And again, now just for a second, I want to talk about a less common cause of small bowel obstruction. Remember from a while ago when we talked about the villi, or when we talked about the embryological development of the GI tract. Basically, we have this thing here called the vitelline duct, which is going to connect the umbilicus, the fetal umbilicus, to the midgut. All right, and usually it's going to involute or is going to disintegrate. Usually, I think it's like by the seventh week or something. But if you have failure of this vitelline duct to involute, you can get a persistence of the vitelline duct, and we call that Meckel's diverticulum. Okay, so Meckel's diverticulum, because congenital, um, um, it's a congenital remnant of a congenital structure. We're going to characterize it as a true diverticulum. So again, you'll learn about this soon, but a true diverticulum is a diverticulum that involves all layers of the gut wall, so the mucosa, the submucosa, the adventitia, the muscularis externa and interna, and everything like that. Whereas a false diverticulum is going to only involve the mucosa and submucosa. Okay, so this is a congenital thing, so it's going to be a true diverticulum. Okay, and when you get this persistence of the vitelline duct, it's going to look something like this. It is going to be connected to the umbilicus, and it's most commonly going to present as painless hematochezia in children. But if it was completely undiscovered in childhood, and this patient grows up and they end up having, symptoms of small bowel obstruction, it could be because of a volvulus or something that's, being formed around this Meckel's diverticulum. Okay, so this is a less common cause of small bowel obstruction. Okay, and the painless hematochezia that you can see in childhood is because inside of the Meckel's diverticulum, you're going to get two different types of ectopic mucosa from the gastric mucosa and pancreatic mucosa. And again, one thing that we know about gastric mucosa is that it secretes acid, or it secretes, hydrochloric acid. And that's going to cause erosion of the mucosa, which is going to lead to painless hematochezia or bleeding. Okay. So again, Meckel's diverticulum is a true diverticulum, is the persistence of the vitelline or omphallomesenteric duct. That's another name for it. It may contain ectopic acid-secreting gastric mucosa and or pancreatic tissue. Most common congenital anomaly of the GI tract and can cause hematochezia and melena. Right lower quadrant pain. Again, that's because we said it's connecting the umbilicus to the midgut, which is going to form eventually parts of the ileum. Intussusception, volvulus, or obstruction near the terminal ileum. This is the diagnosis. It's the technician per technicate scan, which is going to detect the ectopic gastric mucosa. All right, and we characterize by the rule of twos. So it's two times more likely to form in males. It's 2 inches long. It's 2 feet away from the ileocecal valve, so it is in the terminal ileum. 2% of the population, and commonly presents in the first 2 years of life and has two types of epithelia, gastric and pancreatic. All right, now, who can tell me what the diagnosis is here? Take a minute. Look at a couple things. There's this thing, and then if you could see it, this line. So this is a gallstone ileus. Okay. And what causes a gallstone ileus? It's basically the erosion of a stone through a cholecystoenteric fistula. So basically, when you get a stone that's in the gallbladder, it could irritate all the layers of the gallbladder, so the mucosa and the submucosa. And if there's transmural inflammation, if all of the layers of the gallbladder are, undergoing inflammation, that's going to cause a fistula formation between that and the immediate underlying structure, which in this case would be the midgut or the ileum, for example, or the jejunum, or in general, just the bowels. All right. And because the ileocecal valve is the most narrow part of the small bowel, the stone is going to be lodged in there. That's going to cause, first of all, your symptoms of small bowel obstruction. And it's also going to cause these characteristics findings on X-ray. Okay. So what is the name of the X-ray finding? Wriggler's Wriggler triad. And what does it consist of? It's pneumobilia, which means air inside of the biliary system. That's because you have this perforation or this fistula, and then air is going to flow into um, the biliary system. Radiolucent gallstone, which you can see here, and signs of small bowel obstruction, which we talked about already. You get the dilated bowel loops. You could get the stepladder sign, or yeah, the hostrations, the lines going through the entire diameter. Okay. So what are some investigations that you could do for small bowel obstruction? Well, the first thing you're going to want to do is the plain X-ray or the standing abdominal X-ray for air fluid levels in the stepladder pattern. You could do an abdominal CT so that you can see the transition point, where exactly the obstruction is and all the dilated proximal bowels in comparison with the distal parts, which are going to be more narrow. Electrolytes. So with vomiting specifically, you're gonna get this electrolyte abnormality. So it's hypokalemic, hypochloremic metabolic alkalosis. That's because you're losing a lot of the acid that's in the stomach, secondary to vomiting, obviously. CBC, so that you could see the leukocytosis, and lactate. Now, lactate is very important because it's a sign of ischemia. So if you see lactate, then that's sort of not too great of a sign, and you might need to rush your management a little bit. Okay. So for management, you would do fluid resuscitation, you would do bowel rest, which we mentioned, and most importantly, you would do the nasogastric tube decompression. So because of this obstruction, you're going to have too much pressure, like we mentioned before, that's going to, maybe it could cause bowel ischemia and gangrene formation, everything like that. So you're going to do a decompression proximal to the obstruction. You could also do surgery, or you could do something called the gastrographin test. Now, the gastrographin test is both diagnostic and therapeutic. Basically, what it is that you're going to take gastrographin and you're going to basically insert it, and this is for adhesive small bowel obstruction. All right, when there's actual adhesions. So you're going to give 100 milliliters of gastrographin via nasogastric tube. Okay, and then you're going to see the colon after 8 to 24 hours. And if there's gastrographin, if you can't see the gastrographin inside the colon, again, here we're talking about small bowel obstruction. So if you could see it in the colon, then that means it's a partial small bowel obstruction, and the non-emergent, non-surgical management is probably going to be successful. Okay. And the therapeutic part is that it's because it's hyperosmolar, it's going to decrease because it's going to release or relieve some of the pressure that's going on proximal to the obstruction. It's going to relieve that, and it's going to decrease the edema and increase the motility, so that you can maybe have resolution of the intestinal obstruction. Okay. Now, let's think about it for a second. What's a complication that could happen from surgery, especially one where you're maybe having to do like reanastomosis? You're going to have to remove an ischemic part of the bowel and do reanastomosis, and especially create a blind loop. So what's a complication of that? Small intestinal bacterial overgrowth, or SIBO. Okay. So basically, when you have something like a blind loop or something, you can have abnormal bacterial overgrowth, and that's going to alter first of all, your absorption of nutrients. Or you're going to get dysmotility, you're going to get bloating, flatulence, abdominal pain, and chronic watery diarrhea. And also, you're going to have it could also be caused by altered pH, could be for anatomical reasons. And again, because it's causing malabsorption, you could see B12 deficiency and things like that. Okay, so how do you diagnose it? It's through carbohydrate breath test or through a small bowel culture. Okay, all right. Now moving on to arguably the most important part of the pal session, we're going to talk about inflammatory bowel diseases. Okay, so basically, inflammatory bowel diseases can be split into either Crohn's disease or ulcerative colitis. Obviously, there could be something that's called intermediate colitis, which is not very clear whether it's Crohn or ulcerative colitis. Now, it's a lot to try to sit there and memorize every single thing and you know, every single gross morphology finding, single histology finding. So let me try to make it as simple as possible for you. The only thing that you need to remember is Crohn's disease is transmural inflammation, which means inflammation of all the layers of the gut wall. And ulcerative colitis is only mucosal and submucosal. Once you understand this topic, everything else is going to make more sense. And we'll get into it in a minute. And the other thing is that you need to remember that Crohn's disease usually usually begins in the terminal ileum, but it can have skip lesions, which means you can have a lesion in the terminal ileum and at the same time get some other sort of abnormality somewhere else in the GI tract, even aphthous ulcers, for example, in the oral mucosa. Okay, whereas ulcerative colitis is going to be continuous colonic lesions, so it's going to basically spread in a non-disruptive way. It's uninterrupted, and it always involves the rectum. Okay, so because of that, immediately you can start to point out a couple differences. Let's say you get a patient with new onset Crohn disease. The first thing they're going to most commonly, first thing they're going to complain of is right lower quadrant pain because of the involvement of the ileum most commonly. Whereas in ulcerative colitis, since it always involves the rectum, it's going to be left lower quadrant pain. So that's your first difference there. Again, transmural inflammation with Crohn disease, and again, just like I mentioned before with gallstone ileus, when you have transmural inflammation, then it could be you could have fistula formation. So that's why Crohn disease is also characterized by fistulas. You can get these gross morphology findings. Again, these are secondary to the transmural inflammation, cobblestone mucosa, creeping fat, bowel wall thickening, which is called string sign on small bowel follow through. Linear ulcers and fissures. Okay, the main things I want you to remember is the creeping fat, cobblestone mucosa, and the fistulas and fissures. Those are the most important ones that you have to remember. Okay, whereas in ulcerative colitis, since it's only mucosal and submucosal, basically you're just going to be seeing this lead pipe appearance on imaging because you're going to have destruction of those layers of the or ulceration of those layers in the colon. Okay, and it's going to be friable mucosa with superficial and or deep ulcerations, and loss of hostra. So this is what the maybe there's no. Yeah, I wanted to show you guys a extra imaging. We'll find it. We'll look at it soon. All right. Now for morphology, for histology, Crohn disease, you're going to see the granulomas, so the non-caseating granulomas and lymphoid aggregates. But in ulcerative colitis, it's going to be crypt abscesses and ulcers, bleeding with no granulomas. And also you're going to see involvement of the mucosa and submucosa with sparing of anything that's more deep to that. Okay. Complications are things like malabsorption, malnutrition. Now, because Crohn disease involves the small bowel, you're going to see stone formation with Crohn disease a lot more often. So I think it should say somewhere here that there also could be stones. Anyways, we'll look at it soon. So stones are something that can form with Crohn disease a lot more often than they do with ulcerative colitis because you have involvement of the terminal ileum, and that's where your bile acids or things like that are being absorbed. With ulcerative colitis, the main complications are fulminant colitis and toxic megacolon. And toxic megacolon is something that's very, very important. It's basically the highest yield complication that you have to know for ulcerative colitis. And because of this extremely large, very thin walled colon that you can see in toxic megacolon, it could lead to perforation, which is very severe. And again, back to Crohn disease fistulas, which can cause intravesical fistulas, which can cause recurrent UTIs and pneumaturia, strictures, which can cause obstruction. So if they ask you what type of inflammatory bowel disease is most commonly going to cause small bowel obstruction or bowel obstruction in general, it's going to be Crohn's disease because of the strictures and the adhesions, and perianal disease. So you could get a patient with anal fissures or anal abscesses, and that's also going to be signs of Crohn disease. Okay, now intestinal manifestation. Since ulcerative colitis is going to always involve the rectum, it's more likely to have bloody diarrhea, and it's usually extremely painful. Whereas Crohn's disease, you may have diarrhea and you may not, and it may be bloody or it may not. Okay. You have sort of the same extra intestinal manifestations in both inflammatory bowel diseases. So rash, like pyoderma gangrenosum and erythema nodosum, uveitis or episcleritis, oral ulcerations. But again, the oral ulcerations you're going to see more commonly with Crohn disease, arthritis. Okay, kidney stones. So there we go. All right. So you have kidney stones, usually calcium oxalate, and gallstones with Crohn disease. You don't need to remember this. And then with ulcerative colitis, it's primary sclerosing cholangitis, which you guys might not have taken yet, but when you do, just remember it's going to be tied back into ulcerative colitis, and it's associated with positive P-ANCA, which I believe you guys have taken before, P-ANCA. All right, this is your anti-neutrophilic cytoplasm antibody, or another name for it is myeloperoxidase ANCA. Okay. And treatment is sort of similar for both. You can give steroids or azathioprine, immunomodulators, or 5-aminosalicylic acid preparations. Okay. And how do you monitor the disease activity? You could do it through fecal calprotectin, which we mentioned before, is used to sort of assess for any chronic inflammatory thing that's going on in the GI. Okay. So now, inflammatory bowel disease, to go back to the risk factors, there's a bimodal distribution, which means it's common in adolescence and in older age, although it is probably more common in the older age group, but you do see it in adolescents or younger adults. It's going to be more common in the female gender. Smoking is a risk factor for Crohn's disease, and paradoxically, it's also protective of ulcerative colitis. So just remember this very weird piece of information. Family history is always a risk factor. Okay, and pathogenesis, just like any autoinflammatory disease that you have in the body, you get a genetically susceptible individual with a dysregulated immune tolerance, and then, or dysregulated immune response, and you can also have alteration of the gut microbiota, which could also predispose to chronic inflammatory diseases. I need you to also remember that Crohn's disease is Th1 mediated and ulcerative colitis is Th2 mediated. So Th1 is what forms your IL-12, for example, or things like that. So your interleukin 12, which is what contributes to granuloma formation. So that's the reason why you get granulomas in Crohn's disease is because it's Th1 mediated. That's a good way to remember it. Whereas in ulcerative colitis, it's Th2 mediated, which means that the main cell type that's going to be active in ulcerative colitis are your natural killer cells. You also get this gene that you should also remember that's going to be dysregulated in Crohn's disease. Okay, and this is what I mean by the skip lesions in Crohn's disease. So it could be, this is a little bit, by the way, not very accurate because you don't typically get rectal involvement in the Crohn's disease, but it's just good to characterize or to see the skip lesions. Okay. And again, these are skip lesions that could be present throughout the entire GI tract, not just in the bowel. It could be gastric, it could be esophageal, and it could be oral, it could be anything. Okay. And then the ulcerative colitis is a continuous thing, always starting with the rectum. Okay, so let's move on to Crohn's just for a second. We're gonna recap what we said. This is the picture of the cobblestone mucosa that I mentioned before. This is a picture of the creeping fat that I also mentioned. Some clinical features are chronic diarrhea, right lower quadrant pain because of the terminal ileum, or ileocolitis. Now, this is the most common, I guess, region of inflammation in Crohn's disease. Weight loss, ulcers, perianal fistulas or abscess, strictures that are causing small bowel obstruction, B12 and iron deficiency, again, because you got the small bowel involvement, erythema nodosum, uveitis, arthralgia, and then the stones. So it's either calcium oxalate or gallstones. And the reason why this happens is because, well, first let's talk about the calcium oxalate. When you get fat malabsorption, the calcium can actually stick to the fat, okay? And that can cause, well, usually what happens is that calcium and oxalate, both of them are absorbed separately and then they combine, and that's how they're able to become excreted in the urine. Okay, but if you get oxalate alone, that's not attached to any calcium, then it could predispose to calcium oxalate kidney stones. And the reason we don't have as much calcium is that all of that extra fat that's accumulating in the lumen of the GI, secondary to malabsorption, is going to hold on to all of this calcium. That's called saponification, if you guys remember. So it's going to hold on to all this calcium. It's going to cause oxalate to be absorbed like alone. And that's going to cause it to be excreted alone in the urine, which could cause the calcium oxalate stones. Okay. And gallstones for a very similar reason. You get malabsorption of bile salts, and that's going to have it's going to cause oversaturation of cholesterol inside of these inside of the bile, and it's going to cause gallstones. Okay. This is a picture that I want you guys to know. We can characterize the phenotype of Crohn's disease based on whether it's inflammatory, if it's stricturing, or if it's penetrating. These are also a couple different manifestations that you could see of Crohn's disease. So the different fistulas and the different abscesses that you could see in Crohn's disease. So it's called the Vienna classification. Okay. All right. So this is a patient with a known history of IBD. What's the diagnosis? The answer is toxic megacolon. This is associated with which subtype of IBD? We already mentioned this is ulcerative colitis. What's the most feared complication of the toxic megacolon here? Perforation. And then name one gross feature of ulcerative colitis. This is the pseudopolyps that you're going to see because of the mucosal and submucosal inflammation. And which subtype of IBD has a higher risk of cancer? The answer is also ulcerative colitis, and that's because it involves the colon. Okay, I need you to remember that it involves the distal colon, specifically the rectum and the sigmoid colon. Okay, that's why, and also in subtypes of Crohn's disease where there is colon involvement, that also puts you at a higher risk of adenocarcinoma. Okay, so again, this is a manifestation of the toxic megacolon there. You can see you can see the friable mucosa here because of the ulcerative colitis. So, few clinical features are the bloody diarrhea. You're going to get mucus and stool. Left lower quadrant abdominal pain because there's always rectus involvement. Continuous lesions. Continuous, inflammation. Rectal involvement always. Mucosal inflammation only. Megacolon dilation. PSC, which we mentioned before, and inshallah you'll learn more about it soon. Erythema arthralgias, and increased risk of cancer. Okay. And this is what the lead pipe appearance looks like, by the way, on X-ray. Remember here we talked about, yeah, here we talked about the lead pipe appearance, loss of hostra. You see how you can see, I'm not sure I have a picture of a normal X-ray, but if you look at a normal X-ray, you could see the hostrations. I guess you could see them here, these hostrations in the colon, whereas here you don't see any of these illustrations anymore. This is called the lead pipe appearance. Okay. So again, this is more few more summaries for you guys. So the inflammation, microscopic inflammation is transmural and Crohn's disease, and it's limited to the mucosa and ulcerative colitis. Um, you can get fibrosis, you can get a lot of serositis, granulomas, and fistulas, whereas they're all pretty moderate or none at all in ulcerative colitis. You do see a lot of strictures in Crohn's, whereas they're very rare in ulcerative colitis. Okay. And again, CARD15 or NOD2 are genetic mutations that you should, or genetic factors that you should remember for Crohn's disease. And this HLA-DR103 is something that you should remember also for ulcerative colitis. Although they typically, I think, ask only about NOD2, but just memorize it anyways. Okay. Now, which biopsy was taken from a patient with ulcerative colitis? Take a minute to look at them clearly. Well, the answer is A. Okay, that's because we could see here the mucosal inflammation. We could see the crypt abscesses, and importantly, we do not see any granulomas. Okay, it's very, very important. These crypt abscesses are one of the main features of ulcerative colitis. This is an example of Crohn's disease. You can see involvement of the entire mucosal wall, or sorry, the entire gut wall, and you can see this giant granuloma here. Okay, and this is, I think, like this is a villus adenoma. It's unrelated. Okay, how do you treat um, uh, inflammatory bowel disease? There's a couple of different medication classes. You could do steroids, immunomodulators like azathioprine or methotrexate, uh, 5-aminosalicylic acid, anti-TNF alpha like infliximab and adalimumab. You could do anti-integrins or anti-IL-12/23. Okay. All right. Now this is the final, I think, thing we're going to talk about. We're going to tell me what the diagnosis is here. So just to orient you, this is the stomach. This would be the duodenum. See this? So this is a duodenal diverticulum. Now, these duodenal diverticulums, are they true or are they false? They're false. So that means it's only the outpouching of the mucosa and the submucosa only. What causes it? It would be the weakness of the duodenal wall, usually the second part of the duodenal wall. What is the name of the complication that could be seen in duodenal diverticulum? It's Lamel syndrome. And what does it consist of? It's basically obstruction of the common bile duct, which leads to obstructive jaundice and things like pancreatitis or cholangitis. Okay, and that is it for our crash course. Here's the QR code. Please let me know how I did. And if you guys have any questions, please don't hesitate to let me know. and hope this helped. Thank you.